So what is the consensus point one? Should we shift all patients with heart failure with reduced ejection fraction who are on ACE inhibitors or ARNI to ARNI? Then when to switch? Or we should wait till they become unstable? The illusion of stability in heart failure is that if the patient is symptom free, it is presumed that the patient is stable and there is a clinical inertia and therapeutic inertia. The dose of medicines are continuous as such and there is no optimization done because it is thought that patient is stable, symptom free, nothing should be done. But it has been seen from the paradigm of HF heart failure that 20% of stable patients who did not have a history of prior hospitalization, they had a primary event of cardiovascular death or hospitalization. And 17% died during the course of the trial. Out of these stable patients who experienced a primary event, the death preceded heart failure hospitalization in 51%, and 60% of these deaths were sudden cardiac deaths. So a patient is stable, symptom free, but in heart failure with reduced ejection fraction, it does not mean that we should not escalate the dosage, we should not adjust the dosage, we should not optimize the treatment because still the patient is stable and symptom free, but there is high risk of sudden cardiac death, hospitalization. So ARNI should be started as early as possible and we need not wait till deterioration occurs. Even if the patient is stable, symptom free, still then ARNI should be started with the tolerated dose. So far as the 2022 ACEI guidelines for heart failure management with reduced ejection fraction is concerned, there is given class 1 recommendation for ARNI to start from the beginning of the treatment. And when it is not tolerated, then ACE inhibitors can be used. And if ACE inhibitors cannot be tolerated, then there is an option to use ARBs. But ARNI is class 1 indication with level of evidence A in all patients of heart failure with reduced ejection fraction, and it should be started immediately. Is acute decompensated heart failure different from de novo heart failure? Yes. Acute decompensated heart failure means the patient is having heart failure, chronic heart failure. Over and above, he has got acute exacerbation of symptoms of heart failure and he has got admitted. Whereas de novo heart failure means new onset heart failure. There is no prior history of heart failure. The comorbidities are more with chronic heart failure like ischemic heart disease, COPD, atrial fibrillation, diabetic, stroke, history of CABG or PCI, but comorbidities with de novo heart failure are less. Clinical presentation with chronic heart failure acute exacerbation is either dyspnea, orthopnea, lower limb edema, ascites or weight gain. Whereas in patients with de novo heart failure, the clinical presentation is acute pulmonary edema and cardiogenic shock.